What will I gain from this video? After watching this video, you will know how to classify and identify different types of atelectasis on a chest x-ray. Atelectasis is defined by the Fleischner Society as reduced inflation of all or part of the lung. Collapse is used interchangeably with the atelectasis, but usually suggests a more severe form of atelectasis. Atelectasis is a frequently encountered abnormality on chest x-rays. Since the presence of collapse may indicate serious underlying pathology, confident recognition of collapse on an X-ray is an essential skill. There are 5 mechanisms of atelectasis based on cause. 1 is post-obstructive atelectasis, 2 compressive atelectasis, 3 is cicatricial or rounded atelectasis, 4 is adhesive atelectasis, and 5 is passive atelectasis. The most frequent cause of atelectasis is obstruction. The main obstructive causes include mucus plugging, foreign body aspiration, or the presence of a tumor. So in this case, we can identify this opacity within the right upper lung field. The opacity represents collapse of the right upper lobe. The edge of the collapse is irregular because the inferior bulge of the collapse is caused by the obstructing tumor, giving this appearance. The atelectasis occurs as a result of resorption of air distal to the obstruction. Obstruction within the lung can occur at any level of the large or small bronchi. The complete obstruction of a lobar bronchus will lead to lobar collapse, whereas the complete obstruction of a segmental bronchus will lead to segmental atelectasis. Compressive atelectasis occurs when a space-occupying process existing within the thorax compresses the lung parenchyma and forces air out of the alveoli. Here we have an example of a mass within the right lung, which is this oval structure, and we see areas of atelectasis adjacent to the mass that are caused by compression. Cicatricial atelectasis results from parenchymal scarring. The volume loss can occur because the scarring is either directly obstructing the bronchi or is involving the parenchyma and preventing lung expansion. A common cause of this type of atelectasis is chronic tuberculosis or sarcoidosis. Adhesive atelectasis results from a surfactant deficiency. Surfactant lowers the surface tension of the alveoli and therefore plays an important role in preventing the alveoli from collapsing. The loss of surfactant production, or the inactivation of surfactant, leads to atelectasis. This is seen in acute respiratory distress syndrome, ARDS, and other similar disorders. Here is an example of ARDS, and the changes within the lung parenchyma are in part related to atelectasis secondary to loss of surfactant. Passive atelectasis occurs when there is a loss of contact between the parietal and visceral pleura. This occurs with pleural effusions or with a pneumothorax. Air or fluid within the pleural space causes a loss of negative pressure, and therefore there is nothing to maintain the expansion of the lungs to the limits of the chest wall. The elastic properties of the lungs are preserved, and therefore the lungs relax or recoil, which results in the loss of volume. A pleural effusion will cause more atelectasis in the lower lung zones, whereas the upper lung zones are more typically affected by a pneumothorax. In this case, we see a tension pneumothorax that is causing significant collapse of the left lung as well as mediastinal shift. Atelectasis can also be classified based on the extent of involvement of the lung. It can be divided into subsegmental, segmental, lobar, or involving the entire lung. You will review lobar collapse and collapse of the entire lung in subsequent presentations. Subsegmental or segmental atelectasis usually involves the lower lung fields and is most commonly related to the inability of the patient to take a deep inspiration. On X-ray, subsegmental or segmental atelectasis usually presents as linear bands within the lung bases. In this case, the patients had recent abdominal surgery as evidenced by free air under the hemidiaphragms. If we look at the lower lung bases, we can identify linear bands representing subsegmental atelectasis within both lower lobes. In this case, we see linear areas of subsegmental atelectasis within the left lung base only. On close examination, we can identify that the patient has left rib fractures. Because of pain, the patient was unable to take a deep inspiration, which was the cause of the subsegmental atelectasis. In this patient, who also had recent abdominal surgery, we can identify linear bands within both lung bases consistent with areas of subsegmental atelectasis. In this case, we see volume loss within the left lung as compared to the right. On the lateral film, we can identify an edge within the lung parenchyma, which represents the opacified left upper lobe with a left upper lobe collapse. In this case, the patient with weight loss and hemoptysis has this original chest x-ray, which shows complete collapse of the left lung. There is complete cutoff of the airway column due to an obstructive mass within the left hilum. So in summary, causes of volume loss in the lungs can be obstruction of the airways, in which case always think endobronchial lesion, compression of the lung, scarring of the lung, loss of lung surfactant as in ARDS, or loss of negative pressure in the pleural space.